So we're going to launch into just presenting this case, and we're going to get two sides of the story here from Cliff and Ray. So special thanks to Scott Daffner for putting this case together. So this is a 53-year-old gentleman, predominant complaints of back and then left greater than right lower extremity pain, worsening over the past 2 years. You see on the left, it's really kind of a left lateral thigh and anterior leg, and on the right, more of his right buttock, lateral thigh, and into his lateral ankle. Kind of a pretty extensive non-operative regimen here. You can see some injections, selective nerve root blocks at L2 on the left, and on the right at L4, both of which were fairly positive. And you can see kind of the imaging here, both kind of the degenerative scoliosis, about 18 degrees. You can see kind of the diffuse spondylitic changes, the degenerative disc disease at multi-levels, and then kind of the flexion extension views, really without any evidence of instability or spondylolisthesis. So just some of the parameters here, there wasn't much thought as far as, hey, look, this is a big deformity case. It's more of kind of just some back pain, lower extremity issues, less of a deformity or sagittal malalignment. So no SVA, but you can see kind of where we are from lumbar lordosis, PT, PI, and that kind of coronal shift as I showed you before. Here's the MRI. You can see on the far left is actually, that's the right foramen. So you can see kind of the extent of the right-sided stenosis at the L4-5 level, kind of the central stenosis at L2-3, and on the left at 2-3, that level of foraminal compression. So again, axial cuts at 2-3, 3-4, and 4-5 with a subarticular component, just giving you a good idea. So we'll cut to the chase because the story obviously gets more interesting. So this is kind of a 3-level lateral with kind of percutaneous fixation in the back. And the patient did really well. So almost complete relief of the lower extremity pain, really not a ton of back pain. And so, overall, you think about what you provide this patient for these safe, efficient surgery, and they did well. But like Lee Corso always says, it's like the mantra of spine surgery. You think you got away with something, and you don't. So 5 years later, they present now with worsening back pain, bilateral lower extremity pain, worse over the past 6 months, mostly in the L5 and S1 distribution. And if you kind of zoom in a little bit, you can see what's going on at L5, S1. So they get sent off for transforaminals, obviously do pretty well from those, but unfortunately those are just temporary relief, nothing really sustained. Sagittal cuts here demonstrating kind of that extent of the foraminal compression at 5-1, both left, right, and then you can see the axial on what's going on here. So a lot like last night, the Cavalier fans, you're sitting there kind of wondering what's going on. So I got some help for you guys though. So I'm gonna bring in the Halliburtons, and we're gonna show how we really get it done. Okay, so you can go ahead and move to Ray's slide.
All right. I guess I'm going to talk about it from two perspectives. Number one, decision-making, maybe on the initial case itself, which we all know what we did, but my task was to talk about short segment type fusion, particularly lateral. Thanks to the course directors. Thanks, Scott. I didn't know that was your case. Although I have various disclosures, maybe the most important one is that I was trained by Cliff, and so a lot of my thinking evolves from him. So with that, we'll probably come to similar agreements. When we take a look at this index case, if I'm to distill all this history down, this truly is not a deformity case, right? This is monoradiculopathy at L2 and L4. It just happens to happen at the same time, which is a little unique. I don't think I've seen that very commonly. So the first question is, what is the smallest thing that I could do to resolve this patient's complaints? And even before talking about fusion, looking at this patient with really kind of minimal instability is, can you achieve foraminal decompression and resolve the radiculopathy without even thinking about fusion? Maybe. I think it would be a little bit heroic, right? We're talking about over-the-top, foraminotomy, maybe endoscopic. And at the end of the day, that is probably a temporizing procedure, right? But in the wise words of Dan Schuba, every disaster began with a high five. There really is no definitive procedure, right? So you want to do the smallest thing possible to resolve the patient's complaints. And we're all very highly trained now. We can do these advanced lateral, prone, and what I'll say is that at the end of the day, you should come back to those basic principles. So let's take a look at the index case. This patient has a lumbar lordosis of 58 degrees, but their pelvic incidence is fairly high. If you look at their L4 to S1 distribution, 45 is probably right about where they need to be. They do not have a lower lumbar deformity. They probably need to make up a little bit in the L2-3, L3-4 section. And we don't have an SVA. We were asked to assume that it's fairly normative, and it's a minimal coronal deformity. But take a look. What's abnormal? Their pelvic tilt. 42 degrees, right? So you take a look at that, and there's deformity elsewhere. There is upper thoracic or thoracolumbar junction deformity based on these x-rays. Probably upper thoracic spine is driving this patient's retroversion. And so when I'm thinking about resolving a monoradic and not doing heroics and taking a look at this, I think, a multi-level lateral is probably a very reasonable operation with minimal morbidity. And the question is, are you burning any bridges while you do this, right? I always think about trying to preserve corridors in patients who are going to be treated maybe in the future and develop deformity problems. Another thing, having known the outcome, probably hindsight is 20/20, but you take a look and maybe there's a little bit of abnormality in that right spondy to begin with. So maybe my only criticism was at the beginning, I might have CT'd that and may have chosen to include the L5-S1 disc space, not to restore alignment, but only to span across a potentially unstable segment. So when we go back, what do we need to accomplish? Again, neurologic decompression through indirect means is appropriate. Correction of structural deformity, really not that much of a structural deformity that they think you could get it really any way, lateral, T-lift, posterolateral, and reduce the burden of potentially temporizing surgery. For those of us who do lateral, I think you would agree that like a 2-3 level lateral perc screws is a very reasonable operation. Still a big operation, but a reasonable operation for a patient to recover. Just as an aside, I think understanding of optimal spinal alignment truly does exist. Vertebropelvic angles, which have been highly popularized. I think this is a paper that is definitely worth reading and understanding, and then not understanding, and then asking yourself why you don't understand it. But the take home for me is that when you look at pelvic incidence along a spectrum, L4 to S1 actually didn't vary that much, right? So at the end of the day, even in the patient with PI 86, probably don't need to be super hyper-aggressive or do anything heroic again. And another thing to note is that revision fusion does not do well as a primary operation. So we do want to try to define and try to design an operation which will not result in a fairly rapid catastrophe. Now, Cliff is going to argue, maybe for a T10 to pelvis or something longer, but really at the end of the day, he's pretty normatively aligned. It'd be nice to get a little bit of L3-4, and anything long segment, it's probably going to be tricky because the structural thoracic curve, which we're not seeing, is likely driving his elevated pelvic tilt. And so you may think about a smallish large operation, that might be upper thoracic. One thing also to consider, Scott was able to get a 4-5 XLIF. I don't know if he did it through an ATP. I take a look at this, and this is probably like an ATP at the 4-5 level, and 2-3 and 3-4 was reasonable. Laterals to treat this, obviously other speakers have talked about this: decreased DBL, decreased length of stay, decreased OR time, decreased morbidity. And if we go through the MISTF classification for this index case, I didn't realize I was necessarily supposed to comment on the after, but I can very quickly. This is a class 2, and in a class 2, such as this patient, relieving foraminal stenosis, I think this is an ideal case. Now, when you look at the failure distally, I don't know if I have the slides, but if you look at our particular case in the failure distally, I think the answer is fairly equally easy. That's take the level that's unstable and add distally with pelvic fixation across the lumbosacral junction. So speaking to both, I know there's a big height difference between us accentuated by this mountain, but do you really want a long segment for everything, or do you want a short segment by a short king? Shout out to Dom.
Okay, we get a corollary with Cliff Tribune.
Thanks. Where's my clicker here? Disclosures. Actually, related to this topic, I want to disclose that I really enjoy my own personal psoas muscle, and I like retaining it as much as possible. Also, a diagnostic dilemma. If you get into a vessel anteriorly, you're going to know it, so you know what to do with that. So, anyway, another disclosure. I love Ray Hah. So I like a good debate, but candidly, this is not a debate. What Ray just talked about warmed my heart. It is the way I like to think. What's the smallest thing I can get away with? There's zero chance I would have done a T10 to pelvis on this, and I can't really argue it. So I'm going to go over the thought process about all of that. Degenerative scoliosis is ubiquitous, so if you want an excuse to operate, you've arrived at the right time in our humanity. We're all living so long, we all get curves. It is largely benign. It's a radiographic finding. When it's symptomatic, it's typically symptomatic because people get stenosis from this. They'll have a concomitant spondy, or they'll just start settling in their concavity. It should be ignored, meaning the curve itself. You should focus on, there is a rare patient, and I'll show a couple of those because I am supposed to defend the T10 to pelvis approach. But for the most part, degenerative scoliosis, benign, cherry pick the easy parts. So I was asked to talk about T10 to the pelvis, so I actually think about things both ways, even when I'm talking to an individual patient. So what is the argument for going big? What is the argument for going small? So next two slides kind of go about that. I've heard the argument. It's definitive. It takes care of everything. It does absolutely simplify your decision making. If the whole world is a nail and you've got the hammer, you can apply that to a lot of different things. Why is it escalating is the way I think about it, because we're talking about things now that we never talked about 20 years ago, and I'll go over that in a little bit. One of the ones is this first, engaging the patient into the decision process. That's a fascinating thing, and there's pros to it. I think of it in terms of educating the person across from me, and educating them in some cases why I wouldn't do any operation, because they're there to see a surgeon. Here's a surgeon who's got all their biases on his or her sleeve, is getting paid for this, evaluating all the x-rays, all this stuff. And yet if that person says no, take the time to explain why no. But on the other hand, if you're saying, well, we can do the small operation, we can do this big operation, what do you think? My gosh, I can't teach that person spine surgery in 10 minutes, can't even come close. So at some point, I'm going to tip my cards to them and tell them why I want to do what I would do if I'm going to do anything at all. Radiographic parameters. If you think about how scoliosis surgery formed, it did not form because there was a PI-LL mismatch. It formed because you had some people treating patients that were really badly deformed. And they started doing that. And then they learned from it. Now we have a whole series of things going back, looking at what they were doing. And that's not a bad way of promoting education. But it does start putting now the cart in front of the horse a little bit. Now we have parameters first and patients second, and that's kind of a dangerous thing, and that, by definition, escalates care. There's a financial gain for a physician. I don't think that's a deniable thing. You might as well talk about it. I talk about it directly with my patient. In reality, those big operations do have a role. Those patients that our predecessors were operating on, still out there, still coming to your clinic. What I'm seeing here today is most of them coming from ourselves or our colleagues have created them, frankly. What's the con? It's a big operation. It's got a lot of morbidity to it. There is always a next problem. You are not belt and suspenders these things at all. You're actually probably increasing your reoperative rate. And here's the big one to me. If I'm at T10, I'm having a conversation with this patient in my complication doc about their spinal cord. That does not exist when I talk to them about their lumbar spine. And all of a sudden, I'm now talking about that. I don't want to talk about that. I'd like to talk about that way down the line. So, selective approach, save levels. That's just the mantra. I learned that from Dr. David Bradford years ago. Still believe in it very strongly. Smaller operation is less complications, period. I don't see another way of thinking about it. It's actually very rewarding to cherry pick and have it work out. Like, wow, that's cool. Look at all the stuff that I ignored. And it's kind of fun. Now, admittedly, if you undertreat, it's gonna fail, and it'll fail fairly quickly. The index case that we're looking at, 5 years out, How many of you take that? I'd take 5 years out. Could you have minimized it even further by maybe trying that decompression? Keep kicking the can down the road, that big operation. The con, though, is you got to think about it, and you got to get to know your patient a little bit. You got to communicate with them, try some injections, see if you can find out where that pain source is. I'd like to talk specifically about L5S1 because as soon as you cross that line, you are changing the dynamics of your fusions profoundly. So stenosis is quite rare at L5S1. Degenerative disc disease almost ubiquitous. Do you really think elderly with DDD at 5'1" is a symptomatic problem? Likely not. So if you're thinking of fusing L5S1, rethink it, truly. You'll make yourself so much more happy. Yes, the reasons, isthmic spondylitis, the occasional degenerative spondylitis down there, disc herniation, primary degenerative disc disease. It's out there, I get it, but it is not part of degenerative scoliosis and not part of the case we saw today, other than the spondy. And I love the fact that that was ignored. You get 5 years of buffer with a very normal, non-pain generating level. L5S1 in that case was not why that person was hurting. So these are unusual. This is a lady, I still remember her name, came into my practice 6 months into my practice, and she said, my back hurts. And these were anterior posters. I went, well, that's nice. Didn't do a thing about it. No interventions at all. 9 months later, swear to you, no interventions whatsoever. This is what this lady looked like. Her primary operation is going to correct her whole problem. It's a big whack. But that is really unusual. I still remember them. So we have a lot of data. Now, we're generating this data as referencing before. All these things are familiar to you. These are kind of old school slides. Ray was pointing us more recent ones, which are really valuable as we learn more and more about this. But this is what we're now retrospectively looking at our patients and saying, why did that work? Why did that help? And we're trying to apply good science to it. However, these things are distracting and they contradict our common sense. When they are being used as an excuse to do a bigger operation in someone, there's a mistake to that. They should be adjuncts. The adult deformity, Frank Schwab's work was wonderful. It showed that if you're sagittally imbalanced, you have a higher incidence of being dysfunctional because you're crouched in your gait, you're challenged walking up and down the street. That's not universal. That's a higher incidence. You might have people that are crouched forward who just aren't bothered by it. So be very careful about attributing those things without asking your patient what bothers them. There's global spinal deformities. That's where these big operations come together. There's people who crouch forward because they've gotten a little bit older and they're stenotic. That is a reactive spinal deformity. And then there's a local spinal deformity. Can you correct a local one without fusing all down the pelvis? Those things do overlap, and you want to find out what the predominant one is, simply by trying to figure out what their pain is. Here's the problem now. We're normalizing these things. I love the talk on PSOs dying. Well, here's a PSO in essentially my spine. 47-year-old gentleman in European Spine Journal. This was picked as a demo case for a PSO. So now you have a PSO with primary discs open. It's a pseudoarthrosis machine, and I don't know what the heck they corrected there. But if you ask yourself, does every level from T10 to S1 a spontaneous pain generator? I doubt it. Even in our index case, we have L2-3, L4-5 symptoms, possibly. I still am challenged with the idea that two things can happen at once. I agree it can, but boy, I'm tweaked with the idea of just doing a decompression in that case. Again, ADS is really a benign condition, 68% prevalence, so you're going to see it every day in your clinic. 90%, those who are symptomatic, 90% are associated with that stenosis. So, i.e., the deformity is not necessarily the problem. So I tried this in preparation of this talk. I just typed in T10 of the pelvis, so I wanted to look up some papers. But the very first two that came up were complications of that procedure. That thing's 3 pages long. So I thought, well, that makes sense to me. Okay, let me try one other thing. Let me type in PJK. This one I love. So now we start on PJK. This is page 1 of 101 pages of references of a condition that we created. That's stunning. And now we're looking all smart by studying it. Good God, just don't do it. It makes a lot more sense to do a smaller operation and never have that conversation. So, all right, here's a lady. Here's another way. 69-year-old lady. This one's not a pure degenerative, obviously, but you ask yourself, okay, why has this lady done so well? And that's when I start losing those parameters. You look at that lateral view, she's got perfect balance. Her posture's fantastic. Deformity is not her problem. She has to know, so you can see where this is going. So there's a 4-5 spondy that she's got there. She's isolated stenotic there. And there's right there on that MRI to the right, you can see a degenerative disc below that. What did I try to do? I tried to do a floating fusion, and we're now 8 years out on this lady. Brock, I'm sorry, I don't have 2-month follow-up. I'm really old. So the idea here is, do I give experiential stuff or do I start quoting papers? And this is experiential for sure, and therefore anecdotal. However, you're faced with decisions with an individual patient when they show up in your office. This person walked in my office. I know him well. My staff, I'm sure, knows him. 23 years ago. And didn't have any old films, unfortunately. Had a previous wide decompression, developed instability after that decompression, presumably presumably related to that decompression. On the right, you see the lateral. That 3-4 level was autofused. I have a CT that shows that, still open at 4-5. So I was concerned at that time, and I'm going to fly in the face of my rule, but the top of L3 is still kyphotic. And he was in his early 50s, so I did get a little aggressive with this and do this. So that's him. Tried to get L3 above the horizontal. So now I thought, if this guy trashes, he's got a decent base, and we'll see what happens for him. 10 years later shows up, and this is him. So he's breaking down above that level. On that lateral film, just look above. Still looks pretty reasonable. No leg pain at this point, just a dull ache. This is now 4 years after that. He's just climbing right up his spine. Still working. Yeah, it hurts, but he's still got a job. He personally has no interest in doing anything about it. 2021, now he can't stand up straight. Okay, so he's got my attention at this point, and yes, I will show that these big operations do have a role in my practice. This is 16 months post-op. He's getting some degenerative changes up top. Fortunately, no obvious BJK. But that's 22 years, and I could have done that extension of the pelvis back in 2012 or potentially earlier if I'd been following closer. Is that better? You tell me. I don't have an answer, but I like the fact that it took a long time to get there, and now he's in his early 70s, and he's back to doing what he wanted to do. So the question is there a role? I do believe there is. I could have spent the whole last 10 minutes, or actually maybe a little longer, showing cases about, wow, look at that, look what I did, pat myself on the back. But I'd rather be a little more thoughtful about it, and I think the idea of a minimally lateral that was presented was a very reasonable one for that case, and I like the idea that it took 5 years for the next problem to happen. So go big or go home. I'm just going to go home.
That was great. Can you pull up the slides just to do diligence, to do justice to Scott, so we can at least show the final product on that? But that was really wonderful. Cliff and Ray, you guys were the voice of reason for the T10 to pelvis epidemic. If there are any questions, in the meantime, maybe we can get someone lined up. We probably have time for maybe like one or two. So if anyone wants to start coming to the mic, how about we get these pulled up? So you guys see what happened here. So Scott did a wonderful job with an A-lift and then was able to kind of anchor into the pelvis and then link into the old construct. Quick follow-up, but like anything in spine insurance, they're doing great right now. So as always, nothing ruins it like long-term follow-up.